Good afternoon, everyone, and thank you for joining us today for this important webinar on dyadic care. I'm David Hain Menendez, the Mental Health Campaign Senior Advisor for Communications at Children First. For over a decade, Children First has been dedicated to advocating for the mental health and well-being of children across Pennsylvania. Our organization's mission is to improve the lives of our region's children by developing initiatives and advocating for quality healthcare, childcare, public education, and family stability. Today's webinar continues our longstanding commitment to addressing the urgent mental health needs for Pennsylvania's youth. We are grateful to have you with us today as we explore how we can collectively enhance the mental health support available to our children and families. Now, I'd like to hand it over to your host for the rest of the webinar, Kate Fox, the Behavioral Health Policy Coordinator at Children First.
Hi, everyone. Thanks for joining us today. I'm so excited to see so many people here. Today's discussion is particularly timely because, as you all know, we're facing a growing youth mental health crisis in Pennsylvania. And we're here to talk about dyadic care, which is an innovative approach to address youth mental health challenges by providing services and supports to children and their families together. And we'll dive into way more detail today. But we know that a child's home environment and family dynamics play a significant role in shaping emotional and social and behavioral well-being. And by treating both children and caregivers together as an integral part of the healing process, and dyadic care practices can really significantly improve outcomes for our young children in Pennsylvania. At Children First, we believe that access to dyadic care is essential for effectively addressing the mental health challenges that our children face. So today we're here to hear from a range of experts who will share their insights and experiences with different models. We're going to hear from a Pennsylvania state leader and policymaker, a leader in Medicaid reform from California, and then we're going to hear from two different practitioners implementing different models of dyadic care right here in Pennsylvania. We have a very packed agenda. And so to kick things off, I'm going to hand it over to Sally Kozak. She's the Deputy Secretary of the Office of Medical Assistance Programs in the Pennsylvania State Department of Human Services. She's going to provide us with an overview of the current landscape of dyadic care in Pennsylvania. Thank you all for being here.
Thank
Sally.
you, Kate. Thanks, Kate. And good afternoon to everyone. As Kate said, I'm Sally Kozak, and I have the privilege of serving as the Deputy Secretary for the Office of Medical Assistance Programs, and I also serve as the State Medicaid Director. For many of you who don't know me, I'm a nurse by training, and while I've never been a behavioral health practitioner, I am somewhat seasoned with years of practice, and I am well aware of how relationships between children and their siblings, parents, and other caregivers within a family can impact short and long-term physical health outcomes of acute and long-term illnesses, as well as chronic disease. And so I'm pleased to be able to join you today to learn more about dyadic care and its role in addressing mental health challenges for our children, their families, and caregivers here in Pennsylvania. So just a little bit on what is currently available here in Pennsylvania. Within the Department of Human Services, many of our programs use dyadic care models, most notably in our child development and early learning programs, such as our maternal home visiting programs. We are also beginning to see our Medicaid managed care organizations incorporate these dyadic models into their high-risk maternity care management programs. Over the past 3 years, we've made important strides in integrating dyadic care into our mental health system as well. Currently, our program and our plans allow primary care practices to deliver dyadic care services, meaning that families, caregivers can receive mental health support together, which we know is essential for effective treatment. This model recognizes the vital role that family dynamics play in a child's mental health and well-being. So what is it that we're working on across the state? We, within the Department of Human Services, remain committed to continuing to explore opportunities to expand access to dyadic care. And our vision is to be able to create a comprehensive system that integrates dyadic care as a standard practice in mental health services, thereby ensuring that no child is left behind. Having said that, we also recognize that we have a lot of work ahead of us in order to reach this vision, including ensuring that there are enough culturally competent providers available to provide care and to increase access in order to shorten wait time for services. And so to this end, we are actively working on developing initiatives that focus on early intervention, aiming to equip families with the tools they need to address mental health challenges before they escalate. As we continue to seek to expand the availability of dyadic models of care, we will be able to intervene early and effectively, helping children develop the resilience and skills they need for a healthier future. This approach will not only benefit the children themselves, but it will help strengthen family relationships, which we know are crucial for ongoing mental health and stability. And so what I would say, as we explore dyadic care further today, I encourage all of you to consider how we can work together to advocate for and implement these vital services across Pennsylvania. And with that, I think I have the privilege of turning it over to Alex Briscoe.
Hi, everybody. I'm hoping folks can see my screen.
Yep, we can.
Great. So thank you all for joining us. That's really exciting to see the level of interest in this issue. My name is Alex Briscoe. I work for an organization called the Public Works Alliance, and we are working with states across the country to look at how Medicaid can help address the youth mental health crisis. I'm going to move pretty quickly so we can dive into some of the details of how states are addressing this challenge of treating little children and their caregivers together. But I'm going to do some framing slides first. And very briefly, I'm actually a Philadelphia native. Go Pennsylvania. I grew up behind the Art Museum at 26th and Brown. I'm a diehard Philly sports fans. So I'm really grateful to be here. But again, we're working across the nation to help states think through ways they can change their Medicaid system to address the crisis. Behavioral health is the leading cost driver in the American healthcare system. We lose more human potential to mental health and drug and alcohol abuse than we do to any other disease burden. This slide shows you something called daily adjusted life years. It's butts in beds and days on disability. So it's a rough metric. And the reason I want to start here is because when you compare what is called adjusted death rate, which is death per 100,000 in America, to other industrialized nations, you'll see that it's this challenge. Our behavioral health, the rate of behavioral health disorders in America is a uniquely American thing. And why I raise this is it's important to understand the context of the youth mental health crisis, is we are now in a moment where suicide has surpassed cancer as a cause of death for young people. And in fact, in the decade before COVID, we saw a 104% increase in hospital admission for self-injury, a 50% increase in pediatric bed days. And young people were telling us, because in public education, we asked them, but since 2005, young people have self-reported a 61% increase in social and emotional need for support. And post-COVID, as I mentioned, suicide has surpassed cancer. And we are now in this incredible moment. It's horrifying, it's heartbreaking, where 42% of young people experience persistent sadness and hopelessness. I didn't mention this, but my background includes being a therapist in the Oakland Public Schools, working in a level 1 pediatric trauma center, working in juvenile detention and foster care. And then for 12 years, I led one of California's largest health systems. So as I dive into the Medicaid stuff, I just want to say I didn't learn my Medicaid in grad school. I learned it making payroll in a large system with thousands of employees. The reason I show these framing slides, and as we dive into the dyadic benefit, is that to make our systems healing centered, and this is from pediatric primary care to public education, there is no reasonable epidemiological analysis that suggests what is driving these striking increases in utilization and acuity are related to psychopathology. The hard, harsh truth is we have created a toxic culture for low-income children and families, and we must now teach them how to survive and thrive in it. But the good news is there is an incredible amount of interest in this topic. And we had the worst kind of luck, which is while the data I showed you clearly demonstrates that the youth mental health crisis preceded COVID, COVID brought it into the lives and experience of so many people that we're now having a national conversation about the health and welfare of our children. There's unprecedented political will from state Medicaid agencies like Pennsylvania's to the federal government, and Californians and Georgians. I didn't have the data for Pennsylvania, but just picking one Medicaid expansion state and one non-Medicaid expansion state, almost everyone who was a kid or knows a kid knows this is a uniquely difficult time to be a child. And in large part, because of the repopularizing of the adverse child experience study, we are having new and important conversations around the impacts of adversity and the social determinants of health on the social and emotional welfare of children. And things are actually changing. Your Medicaid agency and others are doing a handful of reforms to address this crisis. And there is hope, and it comes from this unlikely place. And while I personally think that Medicaid is sexy, I know that many people, when you say the term Medicaid, it makes them sick to their stomach and they throw up their hands in the air. But what I would suggest is that by making a few essential changes to our Medicaid system, including the structuring of a dyadic benefit, we can transform the experience of children and families. So let's dive into it. There are 5 essential strategies that Medicaid systems are adopting across the nation. And one of them is the dyadic benefit, but I want to put it in the context of some foundational changes that Medicaid systems are implementing. The first is states across the country are removing DSM-5 diagnosis as the barrier to care, meaning we are reimagining how to qualify young people and their families for support. States now qualify for reimbursement based on housing instability, food insecurity, adverse child experience, or even in some states, an experience of discrimination. Basically, if you were listening for all of that horrific data I told you, diagnosis is a poor proxy for need in the lives of children and families. We're reimagining the workforce and the model by adding doulas and wellness coaches and CHWs and peers. We're looking at democratizing mental health service delivery. States are making schools automatically in-network for managed care plans, leveraging portability. And why we're here today is an increasing number of states are looking at ways to adjust or amend their reimbursement policy and practice to treat parents with their children. And remember, like there's a fiercely, fiercely practical thing we're about to talk about, which is that low-income families interact with the healthcare system the most frequently in the first 3 years of their child's life. You did it, I did it, we took our kids in Medicaid do too. But in general, caregivers are invisible to pediatric primary care because they are not the identified patient. And who's going to diagnose a little kid 0 to 5? I'm married to a pediatrician, and if you really want to piss a pediatrician off, ask them to screen for something else or talk to them about mental health. It's essential that we leverage this moment, but there's some real practical challenges. And that's this 5th bucket, which is Medicaid is a pot of gold in DC. To get it, you got to put up $1 to get $1. There's a bunch of different ratios. And what I would suggest is many people, and you're going to hear from CHOP today, the field knows what kind of care it wants to practice, but our reimbursement systems are misaligned with what the field wants to do. So let's dive into this strategy called treating parents with their kids, which is really a framework for the dyadic benefit. So when we say dyad, we of course refer to the child and their caregiver, and almost every form of evidence-based modality in early childhood mental health is dyadic. Like you can't do psychotherapy on a little kid who can't walk or talk. And so all of the models that have evolved over the last 25 years, that we could generally umbrella under the term dyadic care include things like parent-child interaction therapy, child-parent psychotherapy, trauma-focused CBT, attachment vitamins, and more. We're going to focus today on two models that really dive into pediatric primary care and this periodicity, meaning the number of times caregivers take their kids to the doctor. Because looking at these two models will help you understand the opportunities to change reimbursement policy and practice. And I don't mean to just myopically focus on money, but having worked in large public systems my entire career, the way to change behavior is to change how the money flows. And anybody who tells you different hasn't done the work. We have to look at how Medicaid pays and create a pathway for parents to get access to mental health services while they're in the room with their kid. And just remember, in pediatric primary care, it is very difficult mechanically to register the parent because the parent is not the patient. Just there's a very mechanical challenge. Even if the parent who generally is in Medicaid, though some parents their kid could be in Medicaid and they're not, that parent's health insurance is pretty much not even relevant to pediatric primary care. And so there's some mechanical issues we have to get at. And hint, hint, nudge, nudge, one of the mechanical issues is allow parents to get access to mental health services on their child's ID.
Like that one.
So we're going to focus. Sorry, if we could mute, thanks. We're going to focus on healthy steps today, which is, again, just one of a number of dyadic practices. And I want to acknowledge the fact that we don't have to pick a winner here. Like child-parent psychotherapy, healthy steps, PCIT, they're all awesome. They all have amazing clinicians. And it's important, I think, for reimbursement systems and practices not to privilege any specific model, but to create a space where these different modalities can all flower. The reason I'm going to focus on healthy steps is I mentioned my wife is a pediatrician. She works in one of the busiest safety net systems in San Francisco. It's called the Children's Health Center. They're a pediatric primary care that has 14,000 unduplicated children. And she came home one day and told me, oh my God, there's this amazing thing happening in our clinic called Healthy Steps. And I got in touch with a psychologist and she's amazing. And I met her and I was like, wait a second, this Medicaid doesn't pay for this stuff. So we thought a little bit about what it would take to do something at the Children's Health Center that could be a model. What if we pretended as if Medicaid would pay? And on the right-hand side of the screen, you'll see what we did in one of those conference rooms with no windows that hospitals seem to have. We started writing down, what would it look like if it did? And then we wrote a paper called Babies Don't Go to the Doctors by Themselves. And in this paper, we got 2 managed care plans to work with us for a year and reimburse claims as if they could reimburse a set of CPT codes and C codes that did not yet exist in California's reimbursement landscape. And so let me just try to break down the essential reasons for the why of dyadic care and how it works. First, what we know is that children 0 to 5 have the lowest access rate of any demographic in Medicaid. And that's because no responsible pediatrician or therapist can reasonably diagnose a child who can't walk or talk. Is it developmental disability? Is it anxiety? Is it trauma? We don't know. And so it's essential to look at this periodicity question. And so the reason that I want to acknowledge that it's so difficult to diagnose kids, it brings us back to, remember in the package of 5, one of the 5 is remove diagnosis as a prerequisite for care. And what that means is allowing a set of codes to be reimbursed based on other access criteria, generally the social determinants of health, adverse child experiences. We know that low-income families interact with the healthcare system the most frequently in the first 3 years of their child's life. Like, we actually have access to parents. And if you've never worked in a pediatric primary care setting on Well Child Visit Day, it's awesome. There's balloons. It's like a party in the waiting room. People are hugging each other's kids. And it's a unique moment in the American healthcare system where generally the clinician is saying to mama or caregiver, your baby's doing great. You're awesome. How are you doing? Like, it is a uniquely beneficial opportunity to address caregiver mental health as well as address the developmental needs of little children. As I mentioned, babies don't go to the doctors by themselves, but because caregivers are invisible to these reimbursement systems, despite the fact that they're in the room, they're actually in the room. We've never created benefits before for someone who's already in the exam room. But we have to address both the mechanical or structural challenges of registration and reimbursement on a parent's ID who is not accessible to pediatric primary care. And that's why this opportunity to link a child's ID to reimbursement for the dyadic treatment is really the key and essential intellectual change you have to hold to make the systems change necessary to make these services reimbursable at scale. Dyadic models are evidence-based. You're going to hear next from the Children's Hospital of Philadelphia, who is implementing Healthy Steps. We built the dyadic model in California on the back of the Healthy Steps model. So if you kind of want to distill it down, I literally followed this amazing psychologist, Kate Margolis, around a clinic that my wife works in. I literally followed her around for a year and said, what was that? Was that 98064? And like tried to code what she did. And then we packaged those codes in a negotiation with the state. And 2 years later, we had the dyadic benefit. But I'm not even sure what we did was right, because there are other ways besides creating a new benefit in managed care that states are using to scale dyadic practices. And really, I think there are three. There's probably more, but these are the ones that I think I can describe in ways you can hold. The first is a defined benefit, like we've done in California. Create a new benefit called dyadic care, open up the Z codes, and allow parents to get mental health services on their kids' ID. That's what we did. But there are other states, including Arkansas and New Jersey, who are using different models. One is a per member per month payment to any primary care setting that offers these services. They get an extra monthly payment per child that is paneled to their primary care. So remember, all kids are assigned a PCP the same way you and me are. And basically, there's a way for managed care to pay that practice a per member per month payment if they meet certain quality or delivery system criteria. So that would be a second strategy beyond creating a defined benefit. And then a third strategy, I forget whether it's New Jersey or Arkansas is using it, is a per visit rate enhancement, meaning to the degree a primary care home is offering Healthy Steps or PCIT or Project Dulce, they get, I think it's $4 more per visit, including well-child visits and everything, if this service array is available. So are you with me? I want to make sure that the dyadic benefit in California is brand new. I'm not sure we did it right. It's what worked for us in our system. But other states may have and are exploring different ways to scale dyadic services in primary care. Yeah, that was a lot. So we dove down the rabbit hole on Medicaid. But let me just end. We all know this to be true, that a strong relationship with our caregivers is the most powerful mental health intervention known to mankind. What we have to do is make sure that our reimbursement policy and practice is supportive of this connection. And to do that, there are some essential steps, including creating a defined benefit, making a per member per month payment, or enhancing rates for services that meet, for primary care practices that meet certain service criteria. I'm going to stop and pass it on to Chop.
Awesome. I'll just wait for Kate to start sharing the slides. Great. Thanks, Kate. I'm assuming everyone can hear me. Good afternoon. My name is Emma Golub, and I'm a policy analyst at Policy Lab at Children's Hospital of Philadelphia. And I'm joined today by my colleague, Dr. Natalie Minto, who's a pediatrician at Children's Hospital of Philadelphia, primary care in Cobbs Creek, West Philly. And we're excited to tell you about our pilot of Healthy Steps and also our exploration of policy to support sustainability. Next slide, please. And you can go to the next slide too. Thanks. So, I mean, Alex discussed much of this as well, but we know a person's health and well-being throughout their life are so profoundly impacted by the early years and the family context. And pediatric primary care is the cornerstone of a family's interaction with the healthcare system, which is the only nearly universally accessed system during these important years before a kid begins school. And so it offers this really great opportunity to assess the health of the kiddo and also identify and address the needs of the family as a whole. Next slide, please, Kate. Thanks. So what is Healthy Steps? Again, we'll try not to overlap too much with what Alex talked about, but it's a program of 0 to 3 and an evidence-based dyadic care model that integrates a child development expert into the primary care team to do all kinds of good things: promote healthy relationships, foster positive parenting, strengthen early social emotional development, and ensure access to services that address both child and family needs. And so this child development expert is called a Healthy Steps specialist, and they see families as part of the primary care team during pediatric visits for patients birth until they turn 4. Like once they turn 4, it's really for kids 0 to 3. And they offer psychoeducation, anticipatory guidance, counseling, and referrals for common and complex parenting challenges. A little more about the model. Healthy Steps is a tiered model. It has 3 different levels of service and 8 core components. And there's also something called Healthy Steps aligned services. And these aligned services are not explicit core components of the model, but many sites offer them as well. And the most important one of these for our purposes today is psychotherapy. And just to give you a sense of the Healthy Steps landscape, it's currently in 261 pediatric primary care practices across 24 US states, including 3 sites here in PA. Next slide, please. So with philanthropic support and internal investment, Policy Lab at Children's Hospital of Philadelphia is leading a project to implement, evaluate, and explore long-term funding solutions for Healthy Steps within our primary care network. And in June 2023, a little over a year ago, we launched at Cobbs Creek, a practice that serves nearly 3,000 children ages birth through 3 and their families. And patients and families served by this practice often face complex social issues and require clinical, therapeutic, and social services beyond the typical capacity of primary care providers in the span of a well visit. So implementing Healthy Steps has really afforded this opportunity to provide more robust and prevention-focused resources for young kids and their caregivers, but existing payment models do not reimburse for all these services, and so payment pathways are needed to support program sustainability. I will return to that later, but for now, I'm going to turn it over to Dr. Minto to share more about our implementation and evaluation. Next slide, please, Kate.
Oh. Hi, everyone. Good afternoon. I'm Dr. Minto, and I will be discussing a little bit from the provider perspective in terms of implementation. So just to give a little context, a little history, very briefly, I started residency in 2002. There is very little conversation how social factors can affect a patient or a family's interaction with the medical system at that time, and very little conversation about the medical home. So then in 2010, with the passage of the Patient Protection and Affordable Care Act, that changed that, because that particular bill emphasized the implementation and promotion of the medical home. So for a quote from the AAP, a medical home is not a building or a place. It extends beyond the walls of a clinical practice. A medical home builds partnerships with clinical specialists, families, and community resources. The medical home recognizes the family as a constant in a child's life and emphasizes partnership between healthcare professionals and families. So as we moved forward after that to strive to kind of create that medical home, implement that model within our practice, it did create a little bit of pressure, because now during that 15-minute well visit or 15-minute sick visit, we're addressing acute medical needs, chronic medical needs, as well as a lot of some of these social factors. So about 1.5 years ago, when we were approached to try Healthy Steps in our office, it really felt like an answer to a prayer in a way, both for the providers, for ourselves, but we also knew that it was very much needed for our community and for the families that we served every day. So after it was the implementation in our office. We did go back and just check in with our providers to see how they felt the program was going. And as you can see on the right-hand side, 80% of our providers agree or strongly agree that Healthy Steps has helped to improve the clinic workflow and the efficiency in the practice. 75% of providers strongly agree that Healthy Steps has helped to reduce their work stress, which plays a big factor in burnout and avoiding that for a lot of our primary care providers. And then 60% of providers strongly agree that Healthy Steps has helped improve their personal job satisfaction. And that's more than a 2-fold increase from baseline. Next slide, please. So here we have a direct quote and feedback from one of our providers. So in relation to discussing Nora and the benefits of having Nora, who's our social worker affiliated with the Healthy Steps program. So they said, I can't even begin to describe how lucky I feel that we have this. Our families are getting connected to services in a way that I don't think I've ever seen before. It's because Nora literally calls over and over and over again until the kids have services. Not just calling the parents, she calls DCIU, she calls Elwyn, she calls preschools, and she's incredible. And for some personal testimony, just this week, I can say that Nora is also integral in helping to maintain some continuity. Had an infant that was coming back, only 30 days old. 4th visit, I was a 4th provider that they were seeing, but Nora had met the family previous visit, so she was instrumental in providing a little bit of continuity for the family so that they were seeing a familiar face when they came back for this most recent visit. And that goes a long way to helping our families to feel very comfortable. Next slide. And then just for the opposite side, so you can have some feedback from the patient end, we have a quote that parent provided. They said, I really appreciate you and you following up. I'm so grateful to know that someone from my son's doctor's office is thinking about our family's needs, not just his medical concerns, and that there is a dedicated person like you there to spend time with families to talk through these concerns. If it wasn't for you, I wouldn't have gotten my son enrolled in early intervention, and I appreciate the support you gave me after his autism evaluation. Next.
All right, great. Thanks, Dr. Minto. So, and Alex discussed this earlier. So dyadic models of care, including Healthy Steps, have been proven effective in promoting optimal development in early childhood. And unfortunately, in Pennsylvania and in states across the nation, a critical issue is the lack of sustainable funding for these approaches. So most behavioral health services delivered in the pediatric setting are only reimbursable for kids diagnosed with mental health disorders. But as we heard, few young kids match the type, intensity, frequency of symptoms to really warrant a mental health diagnosis from the DSM-5, which was designed for adults, older kids. And furthermore, one of the Healthy Steps specialists' goals is really to help prevent the development of behavioral health disorders. And in the absence of payment, healthcare providers are limited in their ability to offer services like Healthy Steps. Next slide, please. And you can keep going. Thanks, Kate. So our team recently released this white paper, which examines the state funding initiatives for Healthy Steps that are relevant for Pennsylvania. And this information was obtained through a combination of key informant interviews with experts at the Healthy Steps National Office at 0 to 3, and a scan of relevant publicly available materials. And before proceeding, I just want to echo what Alex said earlier. Sort of Healthy Steps is one model within a landscape of programs promoting healthy early childhood development. And Policy Lab recognizes the critical services that Healthy Steps provides, and also really champions an integrated child and family serving system that fosters collaboration. Next slide, please. So I'm just going to review two innovative state payment models today. Starting with Maryland, Maryland Medicaid provides an additional reimbursement of $15 per visit for kids birth till the day they turn 4 who seek care at a practice implementing healthy steps. Medicaid behavioral health services are carved out in Maryland, as they are here in PA, and the enhanced payment is furnished by physical health MCOs, which I'll talk a little more about later. MCOs participating in the state's Medicaid managed care program are required to contract with at least one Healthy Steps site. The enhanced payment does not currently cover all Healthy Steps costs. Maryland sites braid it with funding from other sources. With the funding mechanism in place, though, additional practices are interested in joining the Healthy Steps network. Next slide, please. Thanks. You heard about California from Alex, and I'm excited to share a little more. California's approach to financing Healthy Steps is also through Medicaid, but fee for service rather than Maryland's enhanced payment. Over the last few years, California created a set of benefits within Medi-Cal that really comprises the state's sustainability pathway for Healthy Steps. The first component of this is California's dyadic benefit, which is the first of their kind. And these dyadic services are preventive behavioral health services for recipients 0 to 20 years and their caregivers. So this includes caregiver services provided to the caregiver to support the kid, all of which, as Alex said, can be billed under the child's Medi-Cal coverage. And I just want to draw out that the second component of California's sustainability pathway is Z codes for psychotherapy. So in California, psychotherapy can be covered by Medi-Cal for kids who do not have a mental health diagnosis. And instead, providers can use Z codes. For example, Z65.9 is a problem related to unspecified psychosocial circumstances. So this can be used in place of diagnoses for kids who experience persistent mental health symptoms, have at least one of a set of risk factors, or have a parent or guardian with one of a set of risk factors. Something to keep in mind when thinking about these different sustainability payment models, Healthy Steps in California is most easily sustained when the Healthy Steps specialists are healthcare workers with degrees and licensures that permit them to bill for these services. And in California, the set of benefits is expected to cover much of the cost of Healthy Steps, and the footprint of the program in California is expanding. Next slide, please. Oh, thanks. So now some key considerations when it comes to sustaining and scaling Healthy Steps. The ability to use Z codes for psychotherapy for kids who don't have a behavioral health diagnosis in California is a critical complement to that state's dyadic benefits package. And Z codes are an important component of Healthy Steps funding in other states. New York recently passed this, modeled on California as well. And according to the folks we interviewed, establishing both an enhanced payment and the Z code pathway is another way that could enable Healthy Steps sites to generate sufficient revenue to sustain. So what we learned is the most promising pathway to sustaining Healthy Steps entails really combining Medicaid coverage of Z codes for psychotherapy with either a Medicaid dyadic benefits package like California has, or an enhanced payment model like Maryland, Arkansas, and New Jersey have. Next slide, please. So finally, to think about some considerations for our state, expanding and sustaining families' access to models such as Healthy Steps would be an effective way to leverage continuous coverage for young kids enrolled in Medicaid if Pennsylvania's Section 1115 waiver application is approved. Medicaid behavioral health is carved out in PA, as is the case in Maryland and New Jersey. And those states' enhanced payments are administered through physical health MCOs. Healthy Steps has been shown to improve a range of physical child health outcomes and drive cost savings in that space. There have been recent efforts to use preventive behavioral health Z codes in our state. In 2019, Community Behavioral Health, which is the MCO that provides behavioral health services for Philadelphians with Medicaid coverage, worked with the State Office of Mental Health and Substance Abuse Services to make an accommodation that allowed FQHCs in Philadelphia to use a set of Z codes when one of them is the most applicable for an encounter. And finally, just in closing, it's critical for Healthy Steps sites to work in coordination with other programs and services as part of the larger system that supports children and families. Next slide, please. And thank you all so much for your time. Looking forward to your thoughts. And I think now passing it to Dr. Schlesinger.
Okay. Can you all hear and see me? Okay. I can see me, so I think that's good. Thank you so much for giving me the opportunity to talk here today. I've really enjoyed these presentations and agree with what everyone said, that it's going to take a wide variety of approaches to really meet the needs of our youth and families. I myself have been working in pediatric primary care as a child and adolescent psychiatrist, as well as in the larger health system for about 20 years. If you could advance the slide, we're going to talk about UPMC, CCP, behavioral health. So people have spoken to this already, but I think that, why are we all here? Because we think better behavioral health equals better outcomes. And if we help everyone in the family, both the youth and the parents will do better over time. And it's true that primary care is the place where most parents go to their children for behavioral questions, starting with sleep, appetite, basic behavioral things that have nothing to do with a DSM diagnosis, but have to do with allowing their child to succeed. Once a behavioral health need is identified, a lot of pediatricians and primary care doctors feel like it is like walking over a bridge like this to get to the behavioral health system. So when I began actually as an early career faculty, I had the luck of being in a time and place when our pediatric primary care doctors had gotten together and envisioning had realized that they needed to develop more behavioral health services in order to support the kids that were in their practices. One doctor actually said to me, if we can't do better behavioral health within the next 15 to 20 years, we won't exist anymore. And we're not doing what's right for our kids. And when they came to me, they actually said, we want a psychiatrist. That's what they thought they wanted because they were physicians and that's all they knew. Next slide. Oh. We're repeating there. Okay, so we were able to have a collaboration between Western Psych Hospital and all the outpatient services, Children's Hospital and Children's Community Pediatrics. So although these are all under UPMC, I have to say 20 years ago, we didn't all have a great relationship. And actually Children's had only been under UPMC for less than 10 years, less than 5, I think at the time. So we came together and developed a collaboration and relationships. CCP had patients that were seen in the community and had a group of practices that had originally been private practices that were brought together. Western Psych had the psychiatrist and sort of the expertise in behavioral health, and Children's Hospital was willing to bring some money to the table to help us get the program off the ground. But luckily, because CCP in and of itself is not a non-for-profit. So we were told that we would have to be sustainable, which means all of these wonderful things that we've heard about here today about different mechanisms to get funding. If we didn't have some mechanism to fund, we were not going to exist. So we were told that we'd get a small amount of money to get off the ground, and then we had to be sustainable. Next slide. So from the outset, there was agreement that we wanted a relationship where we had a medical provider, a pediatrician in a primary care practice that would work with a therapist and a psychiatrist. We quickly sort of talked about how, A, there weren't enough psychiatrists to meet all the needs in primary care, but also many youth and families wouldn't need a psychiatrist and shouldn't need a psychiatrist if we got them behavioral health intervention early. As you saw in Healthy Steps, is quite effective. So from the beginning, we agreed that this triadic model with these three providers that could support a patient and family-centered care model would be appropriate. And that if we could figure out how to do it, we could provide better care faster. I think it's also important to note, for those of you who don't know, in pediatric primary care, way over 50% of visits are actually kids 3 and under. And as has been mentioned before, they may not have diagnoses, but they may have behavioral needs. If you could advance, not the slide, but just hit the thing. So we also had a program director to help supervise therapists, oversee quality. That director sees patients. They're not just a director because we had to be financially sustainable. And then we identified behavioral health pediatricians that would become champions, and we had that grow over time. But it was really important. And for anybody that's thinking about doing intervention in any site, but certainly primary care. It wasn't that we could just put our behavioral health providers there and do the job. We really needed to have the pediatricians educate us and be the leaders. Next slide. So what quickly became clear is there were lots of barriers and stigmas related to behavioral health, but I really think there were a few key things that helped us succeed. One was communication, meaning integrating our records. So everything that's done with our therapists is seen by the pediatricians and vice versa. Also, the patient had to be a member of the pediatric practice, check in just like all the other primary care patients, schedule just like they're scheduling with their PCP. Not this is your patient, this is my patient, but this is our patient. And then we shared resources around billing, credentialing, supervision, and education. This may seem like small things, but I think it's really important to note that a lot of times, I've done a lot of this now in the last 20 years, behavioral health providers want to come in and set up shop sort of next door, next to them. And that's great. It's better than nothing, but it's not an integrated practice. And if you're going to be in the practice, you really have to be owned by be a part of the practice. Next slide. So we got together, pediatricians, therapists, administrators, psychiatrists, and we said, what do we think we can do in primary care? This was about 20 years ago. And I call this the ugly slide, but this took a lot of work to say, on the left hand, what do we think is routine care that's done already in the office? And note that PCPs do a lot of primary care, a lot of mental health. And then what's collaborative care that we could work together with a therapist and a psychiatrist if needed to keep this child in primary care and not have to send them on to specialty care. And then on the left hand, we had to do some education about what really needs to go to specialty care now. As well as you'll see that box in the lower left-hand corner, which my therapist felt very strongly. We also needed to educate them. This isn't necessarily something you'd send a therapist to. This is something that you need care coordination for, and maybe we need to help you develop that service as well. So, really identifying roles and identifying what could we work together with to successfully build a behavioral health system within primary care. And you'll also notice on this slide, these words aren't all psychiatry words because we all came together to do it. These were words that everybody could work together to agree. These are the things we think we can do. Next slide. So what did we see? And I'll tell you about how large the system is now, but within the first 5 years, we saw a decreased median age of treatment. So the kids we were seeing in primary care were younger than the kids seen in our like specialty care service. And not surprising, right? If 75% of those kids are 0 to 3, not surprising that the pediatricians are seeing the sort of early signs of distress, but also seeing early signs of things they can intervene on to help. And I think Alex referred to earlier sort of how hard it is for pediatricians, especially if they don't feel trained or supported. But what we found is as they felt more trained and supported, they were more likely to identify. And we'll talk a little bit more about that next. We also saw less children needing to be sent to specialty care. I don't want to at all suggest that means we should get rid of specialty care for mental health. I would say that this should just be like any other medical concern. Most things get managed in primary care, but if you need more help, you should have access to specialty care. Just like if you had a other medical condition like heart disease, you would go to see a heart surgeon. We also saw decreased cost to the health system. And what I was excited about is we saw increased screening. The pediatricians actually asking for how can we screen with validated tools to help identify autism, depression, anxiety, substance risk, suicide risk. And although it doesn't say this on here, because I wanted to pull it out specifically, we also are screening for maternal mental health concerns now too. And quickly able to help sort of move on to the next step, help the pediatricians get the help they need. The cool thing about screening with validated tools, pediatricians have always cared about all these things and asked questions and connected with families. But unfortunately, because we're human as people, there may be built-in issues we have with recognizing people that may not look or act like us or have grown up like us. When you use a validated tool, it helps level the playing field. So we're identifying everyone with these current concerns and not just the people that we understand the best. We also did some chart reviews and saw more patients receiving evidence-based care for depression and anxiety after we trained them. We also saw that as the pediatricians got more comfortable, they started wanting to try new models, wanting to try new things, something that they really hadn't done prior to that. Next slide. Okay. Just so you know how big we've become, this is data from September 30th. So it's not the full year, but I think it gives you a nice idea of the breadth of when you do this type of intervention. So we have 30 practices with hundreds of pediatricians and APPs, over 200,000 distinct patients seen for physical health in the year. And then they're very specific in pediatric primary care, 26.7 therapists, but it's actually like more than 30 people. With over 6,000 of them by September 30th being seen by a behavioral health provider, and almost 20,000 appointments. And we're on target for 28,000 visits this year in all of those sites listed on that map. So a lot of intervention, a lot of ways to get to youth early. Next slide. I wanted to add a few things that on top of this that I think are really important in this area when we talk about pediatricians and primary care. We also have a phone service that's funded by Medicaid that's available for any person in the space, in the state for any primary care doctor who's serving a youth with Medicaid, CHIP, or UPMC. And those doctors can get a pediatrician and a child psychiatrist. The pediatrician can get a child psychiatrist on the phone to help them think about what's best for this kid and family. And we accept calls if they have a parent in the room and they're not sure what to do for the parent's mental health as well. We can't do evaluations for them at the moment, but the state is working with us on developing a line for perinatal services as well. So anyone that has a woman with a perinatal concern could call as well. We also train the pediatricians and developed a family support program where our care coordinators can work along with families to do that really important care coordination that was mentioned in the last presentation. Next slide. Oop. So this is just a few of the models. I really wanted to pull them out to show that how, as the pediatricians got engaged, how much more they were willing to do, willing to screen adolescents for substance use, willing to do brief interventions if we trained them. We then hired a family support specialist because it turns out when you identify kids using substance, a lot of times they're not ready for treatment, but the parents need help. So we're able to provide a centralized person who can help any parent, and we do some groups for them as well. And then we added nicotine cessation on, and now we're doing a collaborative care pilot as well. Next slide. I'm not going to read this. I just put this and the next slide on to show you how advanced my pediatricians became from saying the first day I met them, all we want is a psychiatrist to help us. This was put together by my pediatrician quality group. No psychiatrist was involved in this. And this is what they said they want to work with. And look how expansive it is, going all the way to preventing hospitalization, bridging care, and utilizing care management. And then the next slide is a visioning slide they put together, thinking about, how can we not just provide care, but really change the space? And this was put together by my pediatricians with I hate to call them sorry, I don't own them, but I feel very close to them for this project we do together. They were able, with their therapists that are employed by their practice, to put together this visioning. What more do we need? Going all the way to doing better at population health and getting better at doing data for successful outcomes, which I think is where the whole behavioral health field is. And integration is a fairly young field, and they've gotten there pretty quickly. So it's been a delight to do. And thank you so much for allowing me to speak here.
Boy, thank you. Thank you to all our speakers. This was so jam-packed with just incredible information. We were gonna have a question and answer session. I don't know that we have time for that. We have 3 minutes. And I don't even know how to summarize all of this information that we learned today. This has been so wonderful. I just want to say we recorded this session, so we will send out a link to the recording when it's available, and we can also send the slide deck to you all. We'll send links to, the CHOP Policy Lab paper and our paper about our reforms that we're advancing in trying to advance in Pennsylvania. Children First is, again, just sort of in these beginning building stages. The goal for today was to really build knowledge base in Pennsylvania about these models and this approach to mental health care for kids. We would love to stay connected with you all. We have our contact information here. We'll be hosting a lot more webinars in 2025. So I'm so glad that everybody was able to join today. I hope this was really valuable to you, and please stay in touch with us. Thank you.